and listening to their conversations about the immune system is independent of the cancer type. It's one of the most important messages we're going to take back. So when Mike called me to say, would I come and speak about why we've not won the war on cancer and where we're going next. By the way, is this a slide mover? I'm not sure. Oh, okay, you got control. So this is the first time I've spoken for 10 years. So what happened was, when you think about this, now it's 35 years of work. I decided I'm going to use this mind map that I wrote, and I think Richard Pazder may be in the audience, and so Sean Cozen, because I presented to them at probably the first meetings of the Oncology Center of Excellence, OCE, where I presented to a room of this concept of the cancer vaccine. And I raised the hypothesis that orchestration of the innate and adaptive immune system will drive a concept called immunogenic cell death, rather than a thing called tolerogenic cell death, which we don't have time to go into, with the idea of durable complete remission, independent of the cancer type. So I was trying to recruit academics to my lab, and I wrote on the board in January 2016 what I'm trying to accomplish and the history. And during this time, President Biden, Vice President Biden asked me to participate in the Cancer Moonshot and said, this is where we're going to go. And I call this quantum oncotherapeutics. Because I saw the tumor and the constellation around it was forever changing. So rather than Newtonian physics, where things are static and you hit it with a hammer, what was changing was the tumor was changing itself, and you heard from Jim today of how it evades T cells. But at the same time, the constellation around it was changing, and the constellation is hugely complex, from the killer side to the suppressor side. If I boil it down to the essence, it's a battle between gamma interferon and TGF-beta, if I really boil it down to its essence. But it's much more than that. So I wrote on this board the events that we need to do and how we need to get there, but all at once. So I think of myself as a biological physicist, I suppose. I'm a surgeon that can walk, chew, and gum and talk at the same time. That's what most surgeons say what they do. But I had the pleasure of doing pancreatic transplants at UCLA, in which way I had to immunosuppress my patients. And then I did the Whipples at the VA and at UCLA, which I had to actually fight cancer, and trained under Don Morton, who was developing melanoma and putting tumors into the tissue of patients' melanoma. But I thought to myself, why do that? Why could we not use the tumor itself in the body as the vaccine and disrupt the antigens and explode it? I spent the next 5 or 10 years working on whole tumor genome, and we built one of the largest NovaSeq platforms to look at tumor normal and find the epitopes. And I realized, if you look in the middle of that little tumor thing with the red marks, there's thousands of mutations. We'd be whacking a mole. There's no way you can kill the tumor from the inside out. You have to kill it from the outside in. So this became this mind map. So Mike, if you're going to indulge me, I'm going to take the time to take you through this mind map, little piece by little piece. Next slide. Who's controlling? Next slide. I reduced that mind map to this elegant-looking graph, which I presented to OCE. And if you look at the top, and if you have time at the end, this is what I presented to all the thought leaders in 2016. You needed all those molecules from a GPS-guided, you needed metronomic chemo, you needed natural killer cells, you needed vaccines, you need fusion proteins, you need to understand myeloid-derived suppressor cells, Treg cells. You need to understand the plasticity. Every cell in your body could be an M1 macrophage that kills an M2 macrophage that suppresses it, an N1 neutrophil that kills an N2 neutrophil that suppresses it, T killer cells and a Treg cell. That's the complexity of this plasticity. At the same time, the tumor is changing to what you're doing to it in real time. So how could we orchestrate all of that? And I realized no single company would be able to do that unless they had all that under control. Not control for financial control, but control of an orchestration of sequential interaction in real time. As a tumor morphs, you morph with it. Which meant then you need to go to innate and adaptive immune therapy all at the same time to drive to immunogenic cell death and a memory T and NK cell. Next slide. And this is the meeting. I've had multiple meetings like this. And you could see the skepticism on the faces of all the thought leaders. And you see Mac Cheever, Jeffrey Schlom, and Jim was right. Getting anybody to think immunotherapy as a cancer treatment. And we held meetings and meetings and meetings like this where I was trying to convince my fellow colleague scientists. And they really thought I was crazy, actually. So I decided the only way to do is just go tell things, do this work. And here I am 10 years later. This is the first time I'm presenting, I said to Mike, the work since then. Next slide. So let me go back. Let's step back about why we're here. And there's a lot of elements that's taken us through wrong assumptions, not by any quirk of idiocy or ignorance, but just by a quirk of timing. So if you look at that chemotherapy, how was chemotherapy developed? So I knew Matt Softness, next slide, and he was working hard in developing Taxol. Taxol came out with the yew tree, the bark of the yew tree, and hydrophobically they were developing Taxol. And it almost never passed because people were dying. But the only way they got it to dissolve was in castor oil. We'll come back to that. Castor oil. Injecting women with castor oil. With the black boxes, you have an anaphylaxis regardless. But nonetheless, it was successful, it got approved, and Bristol Myers took it on. And the NCI was then charged of developing a model so they can develop 500 drugs. I tried to show this book to John Stewart and told him with the nude mouse, thinking we're going to have a serious conversation. He said, well, the nude mouse is a mouse without morals. I said, well, that was the end of that conversation. It broke into laughter. But what this war really was, they found a mouse that was athymic, which meant it had no T cells. So think about this, that we developed drugs in a model system without an immune system. Next slide. Which then said, we also develop a regulatory strategy that says, let's go to maximum tolerated dose, MTD. Let's take these drugs that we developed, regardless of the immune system, and put it into the patient to see that we don't kill the patient and just get below MTD, give high-dose radiation, we go chemotherapy, intensive therapy, and that was the beginning of my little mind map that said that must change. Next slide. What nobody realized, this concept of lymphopenia. I'm trying to make lymphopenia famous. It's been famous forever. What is lymphopenia? Lymphopenia is the knocking out of your NK and T cells. Lymphopenia says, let's make you an athymic mouse. Let's make you a skid person. Let's make you without T cells. Well, guess what? Next slide. Christy Mackel, who some of you know. Again, I've been lymphocyte depletion during treatment with intensive chemotherapy, 1994. We've known that we wipe out our NK cells and T cells, the very cells that need to kill cancer with the chemotherapy. I started to say that in one or two meetings and decided to stop, to say, is it possible that inadvertently we are causing metastases to our patients? Is it possible that we are super selecting the resistant cells, wiping out the NK and T cells with our high-dose chemo? We've known this since 94. Next slide. Well, radiation is no different. Radiation is even worse. Since 1983, we've known that radiation induces lymphopenia. We've known now all the way down to this paper was in 2022, and you can go on. Next slide. Yet, a CBC that measures hemoglobin, white blood cells, red blood cell count, neutrophil count called ANC, it measures your lymphocyte count called ALC. ALC is hidden in plain sight. After millions of dollars I spent on genomic sequencing, DNA, RNA, protein, proteomics, it turns out a $10 test is available since 2015 with an ICD-10 code. Next. So what happened? Well, next, Amgen developed. Next. Sorry, you've got to press. Measuring red blood cell count if you have anemia. Thank you. And if you have neutropenia, so you look below there, RBC and ANC. And guess why these drugs were developed? These drugs were developed as a consequence of the side effects of chemo and radiation. And guess why they were developed? So you can give more chemo and more radiation. Now you think of this logic. Obviously, these are good drugs, they're important drugs. They would prevent patients from dying from infection, etc. They're not non-important drugs. I'm trying to take you through the process of how we were thinking and maybe not thinking to this missing link. And this missing link is lymphopenia. In that same test that you measure RBC and ANC, there's a thing called ALC. So what I did is I tested, and I went through this year, just this year, I would call maybe 100 of my oncology friends and said, can you tell me your patient's ALC? They said, the ANC? I said, no, the ALC. And I said, what's that? The reason there's a what's that is even today, I think you could test some of your friends. If there's nothing to treat it, you're not taught it, you don't read it, and you ignore it. So the next thing I need to make famous is, what is my ALC? Because that single test will give you the status of your immune system, i.e. lymphopenia or not. So that was the missing link. The very cells, NK cells and T cells, necessary to kill cancer. So what's the consequences of lymphopenia? Well, who cares? What was really disturbing, and I won't go into details, I had a very recent FDA meeting and I tried to convince the FDA about the importance of it. The response was, well, that's just a number. Hemoglobin is a number, PO2 is a number, blood sugar is a number, ALC is a number. But what's the consequence of this number? Your normal lymphopenia ALC levels should be around 4,000, 2,000, 3,000, 4,000. If you go below 1,500, this is 2015, 10 years ago. Paper after paper after paper, you look at the hazard ratio. If you have a lymphocyte count less than 500 for high-grade glioma, from pancreatic cancer, stage 3 lung cancer, all types of cancers, your hazard ratio goes up 200% of early death. More concerning, and I shared this with Mike just recently, lymphopenia, the question was asked, does a low lymphocyte level associated reduce the survival in the general population? Healthy general population. The answer, 1 in 5 Americans have lymphopenia. 52 million people. Is there a consequence to that? Look at the hazard ratios. From all causes, diabetes, cardiac, if you have lymphopenia with an absolute lymphocyte count of less than 2,000, your hazard ratio goes up 1, 2, 3, 4. From cancer, the increased mortality. I've been trying to convince the FDA today, lymphopenia is important. Immune system is important. Which then says, does it occur across every tumor type? This is 2019. On the right-hand side in that green bar is every one on the references is an individual paper that says sarcoma, Ewing sarcoma, renal cell carcinoma, breast cancer, non-Hodgkin's, diffuse large B-cell, and so on. The hazard ratios of early mortality is significant regardless. So the consequence of lymphopenia is real. So how did we, as again, a scientific industry, go about to this? Well, we look for a T-cell growth factor. And here it was. So my mind map said, wait a minute. If you go to this mind map, guess what IL-2 does? It stimulates the immunosuppressive cells, the Treg cells, the cells that are plastic that go from T killer cells to Treg cells. But guess what we've done in our wisdom? We approved a drug to stimulate Treg cells, immunosuppressive cells, for treatment of melanoma and for renal cell carcinoma. I know this sounds sort of illogical, but it's what I'm concerned about, what I've been concerned about, still are concerned about, is enlightenment at this level of science with every level of our policymakers, including the regulatory organizations. And to his credit, when I presented my idea through Sean Cozen, he invited me to the OCE, they said, you can go ahead. So you think we've learned our lesson, 1992, but look what happened. 2017, Bristol Myers spent $5 billion on putting a pegylation to IL-2. So here we are saying we are spending billions of dollars, thousands of patients, going down the wrong immune pathway, and yet we're getting all the approvals, phase 1, phase 2, phase 3s, and asking the question, why? Well, thank God, by 2006, Thomas Waldman wrote a seminal paper. For the first time, explaining the difference between IL-2 and IL-15. Now it gets very complicated again because the quirk of timing. IL-2 as a cytokine was discovered before IL-15. So the receptor on T cells is called an IL-2 receptor, except the same receptor is actually an IL-15 receptor. Now it gets even more complicated. So this is, well, I don't have time. If you give me the time, I'll go into it. But the IL-2 receptor doesn't require its chaperone called IL-2 receptor alpha, and in so doing, it actually stimulates the Treg cells. The IL-15 receptor on the same receptor requires an IL-15 receptor alpha, and so doing stimulates the NK cells and T cells. Importantly, it stimulates memory T cells because the IL-15 receptor alpha, the chaperone, is bound to the dendritic cell, which means you really need to understand then the whole adaptive system. So the power of IL-15, and guess what he said in his paper? IL-15 activates T cells and NK cells and has a role in the persistence of CD8 memory T cells. That is the holy grail. IL-15 activates T cells and NK cells' role in persistence of CD8 memory T cells. It therefore might be better than IL-2. So I only discovered this workshop report 3 weeks ago. 3 weeks ago. 2007, the NCI, the FDA, the NIH, the AACR, the ASH had an entire review of thought leaders of what are the most important cytokines that could cure cancer. They reduced 120 to about 20 agents, and these are the criteria in which they would rank them. Number 1, potential for use in cancer. Number 2, perceived by the need by independent clinical investigators. But most important, number 3, the potential against different tumor types. And Jim said it in the first meeting you had with him, Mike, in that the first time I saw your video. The immune system is what you're treating, not the cancer. The most profound statement I got was from the Saudi FDA regulators, who had said to me that the work we're doing is we now understanding that the collapse is the collapse of the immune system, and cancer happens to be a symptom. If you treat the immune system, the immune system treats the cancer. That's what this ranking was. Guess what it ranked? Number 1, IL-15. T-cell growth factor, 2007, ranked number 1. And Mac Cheever, who was there in the 2016 meeting, wrote this paper in 2008. The title of the paper, 12 immunotherapy drugs that could cure cancer. So when I say the word cure cancer, I'm repeating this paper, the T-cell growth factor, IL-15. So let's just step back and say, what do we know then? What, over 55 years, we know that through the nude mouse, we developed huge amounts of drugs, identified the NCI panel, the athymic mouse without T cells. Chemotherapy came from that. High-dose chemotherapy induces lymphopenia. Epogen was invented to enable more chemoradiation. Neupogen was invented to treat neutropenia, to enable more chemoradiation. IL-2 was invented, but it stimulates the wrong cell. And then finally, leukine. Now, this is something we really need to worry about. GM-CSF stimulates an immunosuppressive myeloid cell called the N2. So the neutrophils that we think we are increasing is actually going through a thing called the neutrophil lymphocyte ratio. High neutrophils, immunosuppressive low lymphocytes. So what was hidden in plain sight? Lymphopenia significantly reduces survival across all tumor types. Lymphopenia reduces survival in general US population. Absolute lymphocyte count is there in our face, but ignored. IL-15 was ranked number 1, and IL-15 reverses lymphopenia. That's logic to me. That was what I said we need to now address this to pursue this cancer vaccine, and I approached the FDA in 2016. It's hidden in plain sight. The way we approach that is in a quantum oncotherapeutics way. And I made this lecture to some physicists that it's not